Morning,
I was
Ruth.
going to ask if you could go to the other side because this isn't my good side.
I'll do that for you. Very cooperative.
Okie dokie. Happy New Year, everyone.
Happy New Year to you. We're here to refill or create new positions, actually.
That's requesting, the first request is to create a new community mental health nurse position. And I'm going to use the same information that I presented at HHS. It'd probably be helpful for you to also have this in front of you as well. I may not have brought one for everyone, but one is a graph showing units of service for the mental health side of the clinic. The other is units of service for alcohol and drug. Comparing 2016 or 16 and 17. So for the past couple of years, I've shared with my standing committee that we have had an increased focus and demand to integrate physical health and behavioral health in our clinic. And the thinking behind that is it's all connected. There are changes now in primary care settings where behavioral health screenings are taking place. And in our behavioral health clinic setting, we are now required by both OASIS and ONH, those are our two licensing agencies, to gather, assess, and refer individuals who are in need of physical health care. DOH has consistently communicated the expectation to coordinate and communicate and integrate care across the healthcare system in order to improve overall health outcomes. True integration eliminates waste and decreases expenditures, and this is particularly a concern for the Medicaid population, which is our largest segment of population that we serve in the clinic. We currently have one community mental health nurse who's a registered nurse for 1,126 patients on the mental health side and for 1,126 patients total. The mental health on any given day, these are averages, but on any given day throughout the year, mental health typically has about 860 patients and ADAS has 266 patients.
But the total is 1,026.
1,126 patients.
And that's not the number of people that come in every week?
No.
That's the total number
But
of patients.
that's the number of patients that we, at any given time, across the year, are serving in the clinic.
Could one person be on there twice?
No, these are unduplicated.
These are singles.
These are unduplicated.
Okay.
We currently cannot keep up with what is now required by OMH and OASIS in order to gather physical health information, assess, monitor, and refer. This is also an area where we're compromising the quality of care. Additionally, with more and more individuals covered by managed care, there are additional clinical requirements to obtain pre-authorizations for treatment that can only be provided by a medical professional. Our antipsychotic injections continue to prove to be highly effective for a growing number of patients in the clinic, obviously on the mental health side. We anticipated the need for an additional nurse and included this request in our Vital Access Provider Grant application, which went in a couple of years ago. We were awarded dollars to support an additional nurse position, but I held off doing this until I could be sure that we would be able to support the program through the revenue produced once that VAP grant ends. And so at this point, we're confident that once the VAP grant ends, the position will be entirely supported by the revenue it generates. For 2018 and for the first quarter in 2019, the VAP dollars will be additional dollars to those revenue dollars. So it will be that much more ahead if we bring those VAP dollars in.
So after the first quarter of 19, then it's all based on services rendered
Right.
as far as.
It's based on those billable
billable.
services, right? And I have estimates here, well, actually, they're probably pretty close to what we would be looking at in terms of revenue. So the total cost of the position in terms of salary and fringe, according to my calculations, is $72,581. After the VAP grant ends, the revenue produced by the position would be roughly $97,576.
That's revenue not, aside from the VAT.
That's right, right.
So that's like for billable hours is what you're
Right.
basing it on.
The local share actually will go down as a result of adding the position.
Before I ask any more questions, you need to explain this graph to me.
Which one?
Maybe everybody
The
else
VAT grant.
understands it, but I don't.
What the VAT grant you're asking?
What's the total numbers? I assume the total numbers are.
Oh, the grants,
bases.
yeah.
Right. Those are they're what
What's
we
the
call weighted units in the clinic. We measure productivity. Each clinician is very aware of what their productivity goal is from month to month, and we monitor that. And we also compare that to the number of billable services, along with the paid claims, the revenue we bring in as a result of the claims that are submitted for that work.
So these numbers are the actual number of patient visits or?
They're not. Some services are weighted differently than others. So,
Mental health ones for EPS.
yeah.
Oh,
Yeah, one's for mental health and one's for
so what are
alcohol
we
and
talking
drug.
about for this mental health nurse both?
Pardon me?
This position you're looking for, which one are we talking about?
It's in the mental health budget.
Which one?
The,
Wait,
That one's the same.
that's the same one, sorry. There's mental health.
This is the mental health.
sorry about that.
Yeah.
The nurse position would be in the mental health budget, but would also be serving patients on the alcohol and drug side.
Okay. So your service, what you're telling us here is the 7,900 was done in 16 and 17, you serviced over 10,000.
Right, weighted
Correct.
units.
Okay.
Those aren't individuals, those aren't services, those are weighted units. Kind of a different language, but that's what we're required to track.
I guess I don't want you to think I'm picking on you. I'm going to tell you the same thing I told the last person that was on here. We have a budget procedure here that we try to work on and try to meet the cap every year. As far as I'm concerned, you should have had this in last year's budget.
Yeah, and I thought about that.
This is not good. This is not good timing to have all these people coming into personnel to fill these new positions to add them to the budget. Here we are, January. I wonder what's going to happen by July.
When we start working on next year's budget.
Right.
And in July, I wasn't confident, 100% sure, that we would be able to support this position after that VAT grant ended. And, but at this point, we are so busy in both clinic programs, and this position is very much needed now and not, I really am in a place where it would not be good to have to wait to put this position in place.
Well, Ruth, not necessarily you, but I've heard this scenario before, that the money's there, we're going to get it. And next thing you know, we got somebody coming in at the end of the year and say, we're $60,000 short. Because the state of New York didn't come through. We didn't get the funds we needed. So I'm not altogether sure we're going to get the money.
No, the VAP dollars are already
I
here.
believe you think we're going to get it.
No, those VAP dollars have already arrived. They're in a deferred account. And we can't bring those dollars into our budget until we meet certain metrics. Adding a nurse position to the mental health program or mental health clinic is that metric. Once we do that, we can bring those VAP dollars in. They're here, they're already in the
As soon as
account.
that
What you're
mental health
saying-
program, but
Excuse me, what you're saying to us is, there is no additional cost to the county budget. It's being paid for, one, by VAT, and then revenue gain, it's a zero cost to the county.
That's right. And for 2018 and the first quarter of 2019, we'll have the extra bonus of having both. We'll have both the VAP dollars and the additional revenue the position generates.
when do you project, if the committee approves these recommendations, when do you think that these people will start? Because as soon as they start, they'll be generating revenue.
Right. And, I'll have to work, of course, with personnel. I think this will be a challenging position to get filled. Registered nurses,
Are hard to come by.
they're hard to come by and the salaries are competitive, but, we got really lucky.
I don't think they'll have trouble filling it, because I think we have people in-house that'll take that job.
I don't know that that's the case. We would post it and see if there was anyone.
I think we have nurses making less than that.
I think they're probably around the same, the nurses in the public health department, I think actually do make a little bit more
Oh, they do.
based on the current contracts. It hasn't been an issue in the past, I can tell you at least that much.
Based on the zero cost to the county on this, I would move to create the new position.
I would second.
We have a motion made and seconded to approve the new community mental health nurse position. All in favor?
Aye.
Opposed?
Opposed.
Motion carries. And you're looking to create another position.
Yes, this is the staff social worker position, and this would be in the alcohol and drug budget. Again, referring to the units of service, and also keep in mind, I know the mental health clinic looks like it's been way busier than the alcohol and drug program, but that's because we serve individuals with co-occurring disorders, individuals who have both addiction problems and also significant mental health problems. We serve those individuals on both sides, and many of them are served on the mental health side. So that's why in comparing the two programs in terms of productivity or units of service looks like mental health is way busier. In actuality, both clinics have been very busy. We moved to open access a little over a year ago, and this has worked well in serving individuals coming into the clinic from the community. Providing immediate access when needed has improved our ability to engage individuals in the change process. So we keep that front door open. When somebody needs to be seen in the clinic, all they have to do is walk in and they will be seen. And then from that point on, treatment proceeds. As we move into a pay-for-performance environment, or what's sometimes called value-based payments, we know that we have to continue to have open access. And then additionally, the opioid heroin problem has also been a factor in having more individuals coming into the clinic and in need of treatment. At this point on the alcohol and drug side, clinicians' caseloads are way above what OASIS requires, and we're now in a position where it is compromising to the quality of care for those individuals who are receiving treatment services. And I liken it to if you were being treated for cancer and the recommendation was weekly chemotherapy, and instead, because they were so busy, they could only give you, one time a month chemotherapy. That's the situation we're in the alcohol and drug program, where people coming in for treatment through open access, they're not able to get the level of care that they really need in order to make progress.
How many caseworkers do you have?
We have on the
On
ADAS side, I think we have 5.
And
It
how
is a
many-
smaller program.
So you say that there's a big demand, there's increasing demand.
There is an increasing demand. That front door is open, so people continue to come in. We don't have any space on schedules to provide the level of care that individuals need. On the alcohol and drug side, when we get a new admission, typically at the beginning of treatment, that person needs to be seen 3 times a week. They typically have 2 groups, 1 individual, and then as treatment proceeds, then that gets reduced. But typically at the beginning of treatment, there's the need for more intensive efforts in the outpatient clinic. That's been difficult to do because those schedules are just too full. There's just no room on the clinicians' schedules.
So you're getting new people coming in every week?
Every day.
And what are the caseloads on the 5 staff members?
All I can say is they're full. And depending on how often those people need to be seen, but they are absolutely full. I do want to remind this committee that over the past several years, I've consistently adjusted levels of staffing based on the presenting needs in the county and also based on changes in funding. I believe I've maintained a good balance between my role as the LGU or local governmental unit, where I am responsible for the planning and monitoring of all services in the county for individuals who have a mental disability. Doing that while also considering the financial risk and exposure these services represent to the county. This particular position, the breakout, the cost of the position would be, including salary and fringe, $83,167.50. The revenue produced is $88,290.90. So again, this would lower the local share in the alcohol and drug program, and the revenue generated would cover the entire cost of the position.
So that person will have a full schedule pretty much immediately.
Ruth, I'll say the same thing I said on the last position. I'm not in favor of it. And, basically, I felt this position should have been in the AP budget if you wanted it, not coming in January. Adding $83,000 to the budget. I'm not in favor of that.
Is there a revenue generated immediately as soon as this person comes on?
I guess, I say where I'm coming from. I'm here to make county government the same size or smaller. I'm not here to make county government bigger.
Right.
I don't want to make it bigger, not just you, anybody who walks in here.
I understand.
So,
And that's part of the balance I have to find, again, in my role, in being responsible to make sure that we're adequately meeting the needs. I have, through the years, adjusted my programs based on when state aid goes away, the program goes away. I think I've been a good steward in that sense over the years. And in terms of looking at what the need is across the county in the various communities, unfortunately, we're in a situation where this additional position is very much needed.
So if say 2, 3, 5 years down the road, we see a downward trend,
Wouldn't that be
a
nice?
decrease in the demand for the services, you would have no problem in adjusting.
Historically, it's been going up and up and continue to go up.
In this particular area, alcohol and drug, yes. But
But-
yes, and I have done that in the past, and I've done that, with retirements and designations. I'm always carefully looking at the level of staffing. Are we right-sized? I don't want clinicians sitting around with open schedules and with appointments not on their schedules. I want them busy. I'm also in a position now where I'm very concerned about burnout. There's only so much, these folks can do on a day-to-day basis, and the population that they continue to be exposed to. I'm concerned about, the pressure that they're under, and that they might start looking elsewhere.
Ruth,
you know, Wayne does bring up a good point. When did you start seeing this trend? Because to be honest with you, I've seen the trend with, especially with the opiate addiction. It's a concern, but you know, like you said, we're in January, or requesting new positions in both of them. And I thought that the same thing the other day, but did we have an inkling last year when we were, you know, getting the budgets together? Did you have it in the budget? Was it removed or something, or what?
Now, when we
Where
were
did-
working on the budget in July and August, I wasn't sure that, I mean, look at ADAS in the graph. I wasn't confident that that trend was going to continue. But it has. And, you know, I'm in a position now where I would not want to have to wait until a year from now to have that new position in the ADAS program.
Because, you know, I'm looking at also, you know, the Veteran Services Coordinator position. That needs to be funded and needs to be funded properly. I think what was possibly budgeted, I think it's going to be a lot more than that. And so, you know, there's only so much money that, you know, you're going to be able to get through finance and such. And so we've got to definitely look at this. I mean, I know that the
It's a
other day,
revenue producing position though.
but
from the
also the Veteran Services Coordinator position is a revenue producer.
Let's deal with.
Right, but what I'm saying is, this should have been at least put in or something if we saw this.
How certain is the revenue piece?
We base the revenue numbers I gave you for both positions, but now we're talking about the AD social worker. We base that on what we're currently bringing in, you know, what a full-time staff social worker is bringing in as a result of doing that work.
So who pays that?
Medicaid, third-party insurance, so your Excellus, Blue Cross Blue Shield, managed care plans, so insurance plans.
So if people have insurance, why are they going to a public clinic?
We're the only OMH and OASIS outpatient licensed clinic in the county. And the clinic is, for many folks, the only option. The fact that we're county operated, I guess we're public, you're right in that sense, but we are a medical setting, just the same as a primary care for UHS or Bassett.
So if I had a medical issue, if I had a mental issue,
Mm-hmm.
which my kids sometimes think I do, but anyway, I have good insurance.
Mm-hmm.
I have a primary doctor. And if they thought that I needed counseling or whatever, they would refer me to your office
That's
for
quite
those
likely.
kind of services
Quite likely.
as a specialist?
Mhm.
Yes.
Yeah, there are psychiatrists and psychologists
Mm-hmm.
and social workers to do that, and that's what they're all about.
And we work closely with primary care providers in the
But-
county.
There are,
It's the only,
Ruth, have you ever seen funding go away?
I see it come and go,
Yeah.
and I adjust my programs. I mean, we saw, remember a case management program? I think there were 5 positions in that. When that went away, that program went away. I'm not happy about it, but I understand that.
Are there consequences for running afoul of OASIS guidelines?
We get our hands slapped on a monthly basis when we are, we have a lot of data reporting with OASIS. Nothing beyond that at this point. But I look at it as a quality of care issue. The reality is with caseloads so high, people are not getting the quality of care that they really deserve and that they should get in an OASIS licensed clinic.
so what'll be the committee's pleasure on this Mr. Social Worker position?
I'll move that we fill it.
I'll second.
There's a motion made by Mr. Grace, and seconded by Mr. Starr. Any other discussion on this?
Yeah, Ruth, are you going to, if you get these, the second one approved and the first one, are you gonna come to finance and increase those revenues, or don't you
Yes.
need to? You-
No, I checked with RC this morning.
You are
and
going to?
Right.
Okay.
Unfortunately, Christie isn't gonna be with me at finance.
This motion would go to finance anyways. That's what,
Motion made and seconded.
I think that's fine.
All in favor?
Aye.
Opposed?
Oppose.
So carried.
Is that- I think the sheriff is next, right?
Before this lady leaves, may I ask her a question?
If it's a quick question, yes.
Yes, it's about this. Do you think, years ago, my husband and I were both privy to county services. And they were the best that we could have asked for. This was many years ago. I'm wondering, do you think that we need more education among the adults in this community, at least here in the county building, about this? Because it's ridiculous that you have to keep doing this. When the need has not diminished or stayed the same, it grows exponentially. And I know that. And I hear you very eloquently, and I don't know how you even hold yourself together about this. But you need the money to run the programs because it's more expensive if you don't do this well than it is to provide the money to do the job right. And she sounds like she knows what she's talking about.
She certainly does. She,
And I would just say, as far as educating and raising awareness, I mean, that is part of the role I have as the LGU, the Director of Community Services, is to work not only with folks in this building and involved in county government, but throughout the communities in the county. So I take that very seriously. We look for opportunities to raise awareness and educate. There is still a great amount of stigma involved in terms of behavioral health conditions and how to respond and how to take care of those conditions. But that's just something that we have to continue to work on. So thank you.
Well, it cuts
Thank you.
across all classes, from the top to the bottom and back again.
I
Thank you, by
understand.
the way.
All right.
Have a good day.
thank you, Ruth.
Thank you.